It's Carmen. I found Carmen, Joel, Jim McNamara, Wayne. Joel could get them, could probably get them all, but those are the ones.
Isn't that right?
Oh yeah.
Is this Atif? That's Bert.
Armin Savitt. Not Atif.
Not Atif, okay. All right, we'll do a name that. Warren Strittmatter for sure. Who's this, Joe? He looks familiar.
Don't know.
Maybe I'm wrong.
Jim Burke between Carmen and Joel.
Yeah, there he is.
Bert Scott. Did you?
Yeah, I said Bert. Yeah.
Okay.
Great.
Marvin,
Marvin. Yep, yep.
who looks the same.
He's a little
Hi,
thinner.
Marvin.
Thinner.
Barry Hurwitz.
Uh,
Barry
which-
Hurwitz
Which one, Janice?
behind McNamara, between Carmen and
Right
McNamara,
here. Okay, gotcha.
right there. Mhm.
And Rich, that's me, Kevan, in the far right upper. Don Schmeckel's below me.
Yeah, Don Schmeckel.
Dave Hosford,
Yeah,
behind Cheryl Bushdell and Emma Ciappelloni.
yep.
Good time. We'll post that with all the names on it. Thanks, Will. Again, Hat John. And today's case presentation is Paige Sutton, who's the neuroimmunology fellow. So Paige, take it away. There it is. We've got it.
Thank you. Good morning, everyone. I am presenting a case from Neuroimmunology Clinic today. And it's the case of a 72-year-old female who has history of diabetes, hypertension, and recent onset of headaches. And she was otherwise in her normal state of health until she had this sudden onset of dysarthria, facial droop, generalized weakness. And that led to a hospitalization where she got an MRI for stroke workup. And it showed this subtle left occipital hyperintensity on T2 flare image. So she was discharged a couple of days later. And when she followed up with an outside neurologist, her daughter reported that she was having some cognitive decline over the previous few months, specifically issues with delayed recall and attention with a MoCA around 24. And a repeat MRI was ordered to follow up on that lesion. On the repeat MRI, you can see that the left occipital lesion has expanded in size, and there's a new right frontal lesion. And neither of these enhanced with contrast or had restricted diffusion. And then on SWI, you can see there's some scattered microbleeds. So she followed up with a couple of clinics to try to figure out what was going on, including the oncology clinic and stroke clinic. And after some workup, she ended up in neuroimmunology, where she was diagnosed with probable cerebral amyloid angiopathy related inflammation and started on oral steroids at 60 milligrams daily. A lumbar puncture was also performed at that time, which showed normal cells, normal protein, no oligoclonal bands, negative infectious workup, and cytology. A repeat MRI was ordered after she'd been on steroids and showed that these lesions had completely resolved, and her symptoms also resolved. She was no longer having cognitive issues or changes in speech. So she was started on mycophenolate for steroid-sparing therapy, and the oral steroids were slowly tapered. And on follow-ups after that, she was clinically stable, off of the steroids, remained on mycophenolate, and her imaging remained normal. So cerebral amyloid angiopathy is a cerebrovascular disease where amyloid beta is deposited into the blood vessel walls and commonly presents with lobar hemorrhage or cognitive impairment. CAA-related inflammation is when there's an autoimmune response to this amyloid beta, and that causes inflammation. So there's two subtypes to this: inflammatory cerebral amyloid angiopathy, where there's perivascular inflammation, and then amyloid beta related angiitis, where it's intramural or transmural inflammation. So the definitive diagnosis can only be made by biopsy, but there are these clinical radiologic criteria that were developed to help some patients avoid the risks of biopsy. So using our case as an example, our patient was over 40 years old. She had 2 of these clinical features, including her new headaches and focal neurologic deficits. Other common presentations are seizures or decreased consciousness. Her MRI showed multifocal white matter lesions that were cortico-subcortical, extended into the subcortical white matter, and were asymmetric. And she had over 1 hemorrhagic lesion with the microbleeds on SWI, and absence of other causes after her extensive workup. This criteria was found to be very sensitive and even more specific for the diagnosis of probable CAARI. So the treatment when you have a probable case is to use high-dose steroids, plus or minus an immunosuppressive therapy, and some that have been used in the literature are listed here. There's not a single one that's recommended. And if there's no response to treatment after about 3 weeks, it's recommended to consider biopsy to look for another cause. The prognosis in untreated patients is poor, and there's a possibility of recurrence after stopping steroids. But one study showed that at 24 months on treatment, over half of patients were asymptomatic or had mild disability, similar to our patient who's almost 2 years out now. So thank you all for your attention, and thank you to the whole department for a really wonderful fellowship year.
Thank you, Paige. Great talk. Right in 5 minutes, just like you said. To introduce today's grand round speaker, I'm going to throw it to Chris Eckstein.
Thanks, Rich. So we continue with our Chief Resident Grand Round series as we approach the end of the year. So today we're going to be hearing from Ryan Ghusayni, who comes to us from American University of Beirut, where he did his medical and pre-med training. He actually spent a year afterwards doing research in with Dr. Makati in the pediatric neurology group, where he was able to publish several manuscripts and had a fairly prolific year, and then came to residency with us, obviously. So I think we're very fortunate that he's going to be sticking around doing neuromuscular at Duke, and means I'll have someone to ask all my peripheral questions to next year. And today we're going to be hearing about functional neurologic disorders. Take it away, Ryan.
Thank you, Dr. Eckstein, for that kind introduction. So let me share my screen here. All right, looks like we're seeing it. Okay, so today I'm going to be talking about functional disorder and specifically addressing this question. Are we explaining it correctly, both to ourselves and then subsequently to our patients? So I'm going to start a little poll. Let's see if it works. I don't know. So text Ryan Ghusayni 186 to 22333, and I want to know, what's your favorite way to explain functional disorder to your patients? I know everyone kind of develops their favorite way to do that. So let's see if the results start trickling in.
Are you asking me?
Dr. Roger, I know your way. You know, OGK, only God knows.
One way to say, you're just crazy.
Right. I mean, at least that's honest,
I saved that for last.
I know.
I think stress is probably one of the kindest ways to talk about it.
Actually, like the first time I heard that, I was like, I don't know, it's just you're saying a stress reaction and then you're leaving the room. But if you've worked with me, I like being efficient, so that's like the most efficient way. And it kind of acknowledges that, if the patient hates you afterwards, you're not too stressed about it. It's like, it's a stress reaction, let's move on.
The trouble is the comeback to that is usually, I'm not stressed. I don't have any stress. I got lots of money. I got lots of kids, and everything. And I said, well, it sounds pretty stressful to me, having all those kids.
Yeah, for sure.
That just kind of gets you into it. There's a long conversation after that. That's my introduction usually.
Hi, this is Janice Massey. I have a comment. Can you hear me?
Yeah, I can hear you.
Okay. I usually start out by saying that I think we've got good news because we don't find any terrible disease
Yeah.
that would be calling it, to name. And then I also say that sometimes we see stuff like this in neurology that we don't fully understand. And often over time, it just goes away. So that's kind of my trick on it. But I also will schedule them to come back again in, whatever I consider 3 to 6 months, in part so they don't get out and get caught up in the mega workup and mega treatment by somebody else. So I kind of consider it to be protective. And at that time again, I can reassure them that we're not finding big, bad disease.
Okay. Yeah.
So
Thank
I have other, a lot of it depends on the patient, the approach, but that is a common approach that I have.
That's a much better answer than mine. Thank you.
Yeah, thank you, Drs. Roger and Massey. That was helpful. So it looks like I'm getting the results, but not on the screen. So I'll just read to you what the results were. Stress reaction, we have 20%, hardware software problem, 28%, physiologic response similar to anxiety is 44%, so that's the most popular. And then don't know is 8%. So I want to talk about a change in DSM criteria that happened relatively recently that kind of surprised me, and maybe it'll kind of surprise you as well. But so there's a DSM-4 criteria, and most of it is what you would expect, except criterion B and C, which I have highlighted there. Criterion B says you must find psychological factors that are judged to be associated with a symptom and preceding the onset of the symptoms in order to diagnose this disorder. And then criterion C says you have to prove that the symptom or deficit is not intentionally produced or feigned. And honestly, I don't know how you're supposed to do that, but those were the official criteria as of 1994. And then DSM-5, which was published in 2017, got rid of criteria B and C. So I can see why criterion C was gotten rid of, because I think it's impractical to prove that someone's been feigning and not feigning. But I wonder what the implications are, or where that criterion B being eliminated came from. What are psychiatrists thinking about the association of psychological factors with this disorder? And so going into the literature, it seems like this has been a long time coming. Several psychiatrists who are prominent in the research of functional disorder have been advocating for this change. I'll read you some quotes here. The idea that conversion disorder should be a psychiatric disorder is one that requires justification. The failure to find a neuropathological explanation clearly isn't sufficient, since that would apply to many disorders considered neurological. Finding a psychological explanation does not seem to be universally possible in conversion disorder. That's what Nicholson says. The psychological association criterion appears to us to be both theoretically and clinically problematic. And this is my favorite. It is not merely that psychiatrists don't come across conversion disorder anymore. It's that when they do, they don't see it as psychiatric. And the regular lament of neurologists sending their functional cases to psychiatrists today is that they are simply sent back with a note saying there's nothing psychiatrically wrong with it. So I think this shows a disconnect about how we view it and how psychiatrists view it, because I've always been taught, this is precipitated by a psychological disorder, send them to psychiatry. Obviously, rule out neurological causes, explain the disorder and send them to psychiatry and they'll be fine. But then psychiatrists seem to think differently. And so kind of let's take a step back and see how we got to the current understanding of functional disorder. And by that, I mean the most prevalent understanding.
Hey, Brian, you need to, your screen isn't working. All I can see is my name.
Your name? Oh, okay. It's working for us in here.
Okay, that's okay then. Go ahead.
Okay. If anyone else has screen problems, please let me know. So go ahead and vote, and I think I'll probably get the results there. So where do we get it? Functional neuroimaging, electrophysiology, pathology studies, or a 19th century psychiatrist who also used and prescribed cocaine to his patients. Anyone know who that is?
Freud.
Freud, Sigmund Freud, yeah.
He was a neurologist, Ryan.
Sorry?
He was a neurologist, not a psychiatrist.
I guess back then there wasn't really that divide between neurology and psychiatry. But yeah, I mean, back then it wasn't illegal, and folks still, thought it might be a treatment for things. So I'm not blaming it for that. I'm just saying be frowned upon these days. All right, we're getting some responses. I think sometimes it would be helpful to describe cocaine to patients. All right, let's see what we got. Okay, so 26% says functional neuroimaging, 9% says electrophysiology, 4% says pathology study, and 61% says D. I think that was kind of begging the answer. But so, yeah, D is correct. So let's look at the history of the disease. So this disease has been around for a while. It used to be called hysteria. It's described as far back as ancient Egyptian times, and many different models emerged over the years. Some said it was a movement of the womb, spiritual possession, nervous irritability, gynecological reflex. There's obviously a misogynistic undertone there. But by the 19th century, folks just thought they were faking it. They believed it was deliberate stimulation until Charcot came along. And Charcot, as most of you know, is the father of neurology. He was, kind of a great organizer of neurology. And he liked collecting, patients with the same syndromes and then doing autopsy studies and figuring out what sort of disease they had. And that's where we get the names multiple sclerosis, amyotrophic lateral sclerosis. So he's describing a neuropathological finding. And so he did do postmortem analyses on functional patients. And that's where the word functional came from. He didn't find any structural thing wrong with them, but he thought there was something functionally wrong, similar to what happens to migraine. It was in the same basket back then. He believed it was caused by hereditary predisposition with environmental agents superimposed. And he argued it was neurological rather than uterine, which I think is the first kind of argument for that. He said it was not a maladie imaginaire, so patients were not making it up. It was not a random and meaningless collection of symptoms, and he was working to organize these. Again, he's a great organizer, and I think that's where we get our neuro exam from. Freud, his student, said he actually restored dignity to the topic. And this view was popular during his life, but it didn't last long after his death. And that's thanks to Freud, his student. So he coined the term conversion disorder, and he kind of took a different view of it. He thought it was consisted of two steps. Number one, repression of a traumatic idea, and then somehow this was converted into physical symptoms that we see. Focused on the repression part more. He said the repression is deliberate, as in the patient does not want to experience that traumatic idea, but then the effect is unintended. And this was possible due to his idea of the unconscious, right? So the patient was made the victim rather than the perpetrator. So folks were, so folks were kind of becoming more convinced that this isn't feigning. And he believed in the cathartic method. So he said it's enough for the patient to recall the traumatic experience and then they're going to be cured. And apparently he had some success with the first few patients that he saw with that, although there's some debate about that. One of his patients later claimed that she was never cured. But, as he saw more and more patients, it stopped working. He couldn't find any psychological factors. I think maybe someone's logged in, but is anyone logged into Ground Rounds today?
I can hear a reverb of that.
Yeah. Anyways, okay, it's okay. Maybe we ought to mute. Sorry, guys, it's getting some feedback here. Let's mute this in case there is some speaker. Let's see if
We don't have any feedback out here.
Yeah, it might be in your room since you've got the DCT login too.
Yeah, I think we fixed it. All right. So, anyways, so it stopped working, and so he had to reach farther and farther back into patients' histories to find these quote unquote traumatic experiences. They became increasingly diffuse, circuitous, going back to childhood and even infancy, and then they became increasingly sexual and highly elaborate. So he was kind of grasping at straws to find something to blame this conversion disorder on. Initially, he was trying to figure out what the neurophysiology was talking about cortical excitation and so on and so forth. But then later in his career, he was focusing more on the symbolic and associative meaning of conversion disorder. So how did this become, embedded in our understanding? So there was an epidemic of functional symptoms coming in soldiers coming back from World War I, commonly called shell shock. This for the first time confirmed that these symptoms are not gynecological because it was happening in men, but it also created immense pressure on doctors to try to differentiate between functional disorder and malingering. And so that's where they focused on Freud's ideas. It created an enduring interest in psychosomatics in general. How did it make its way to the US? So it wasn't readily accepted here, but thanks to backing from the Rockefeller Foundation and Adolf Meyer, who was a psychiatrist in chief in Johns Hopkins, those were two big proponents of the psychoanalytic school and kind of helped bringing it over here. And then, of course, we had European immigrants fleeing Nazism and who were in the psychoanalytic school. But in the UK, the Freud's ideas were not as readily accepted. And it's actually interesting because a lot of the psychiatrists I mentioned are from the UK. But there was an anti-psychoanalytic movement forming there, eventually made its way to the US. And then Robert Spitzer, and then Robert Spitzer, a psychiatrist at the US, was appointed as a chair of the DSM task force. And he was interested in a more scientific understanding of psychiatry, as in Freud was pseudoscientific. And so he stripped the DSM-3 of all Freudian theory, except he kept it in conversion disorder. And that persisted until the most recent iteration of DSM-5, which I thought was interesting. And so to me, this looks like what we call an anachronism, right? We're taking an idea from a long time ago, and we're trying to apply it to what we see in patients today. And I think to me that explains a lot of the pushback we get, because Freudian ideas are not very popular in psychiatry and the society in general. And so when we talk about conversion disorder in different iterations, whether it be stress reaction or whatnot, it's a little challenging to swallow, just because we've kind of moved on from Freud. But so if Freud is not right, what is the alternative, right? And so let's look at the objective data that's been published since Freud. And so I'm going to look at 3 different types of data.
This is Rich. I have a question. So in conversion disorders, do you include people with chronic headache that doesn't seem to respond to any medications? Is that kind of included in this group? Because there's a lot of talk about, childhood events and things of that sort in that group.
In the new, more recently, it's been included, and so has things like PPPV, postural, persistent dizziness.
Really?
And so more and more things are included under the banner of functional disorders.
Okay.
Yeah. I'll link to a review at the end that I think is very helpful in the subtypes of functional disorder. Anyways, so I'll talk about 3 different types of studies that are found: association studies, functional neuroimaging, and treatment trials. So starting with association studies, here's our pyramid of EBM evidence. So I'll be talking about a systematic review. So this is a systematic review of stressful life events and maltreatment, and how is that associated with development of functional neurologic disorder. The reason I like this trial is it limited itself to case control studies, whereas other meta-analyses kind of looked at uncontrolled studies. And it looked at studies a long period of time, 1965 up to 2016. So pretty thorough, I think. Here's their figure 1. And so from 1,189 studies that they got from their algorithms, they distilled it down to 34. They excluded studies looking at physical injury or physiological events as risk factors, and I'll address that briefly later. In total, they had a decent amount of patients, 1,405 and 2,227 controls. Those controls included healthy patients, patients with neurological disease, and patients with psychiatric disease. They used the Newcastle-Ottawa scale to determine the quality of the studies, where, for reference, a score of 5 is considered fair. And you see that the quality varied, right? And also heterogeneity was high. So just things to take it with a grain of salt. So see, heterogeneity was up to 86%. And as a reference, anything above 75% is considered high. So I'll just jump ahead to the results here. There was an association between stressful life events and the development of functional disorder, whether you compared these patients to psychiatric controls, neurologic controls, or healthy controls. And it was more likely to happen if that traumatic event happened during childhood rather than adulthood. So 13.4 versus 2.9. And it didn't matter when it happened. It seemed like it did. So If the life events preceded the onset, that was statistically significant, but adult life events in general, kind of going back throughout adult life, did not seem to be statistically significant. So I think probably what Freud was doing was maybe a little overreaching there. I love this scatter plot. So 13 of the studies also looked at patients who developed functional disorder but did not have stressful life events. And these were assessed by various different methods. The LEDS there is probably the most thorough one. It's the life events and difficulty schedule. But also other studies used, their own questionnaires. You can see, and the blue squares are folks with functional disorder that did not have any stressful life events. And you can see it's kind of across the board, but it's in some cases goes up to 80%, assessed by LEDS down there. And so I think to me, this signifies two things. Number one, of course, correlation does not equal causation, right? And here, using this study, we're looking at risk factors. And so we can't say the stressful life events explains the whole picture. And number two, I think, those blue boxes kind of translate to clinic, where you're seeing a patient and, they tell you, they swear they don't have any stressful life events. You send them to psychiatry and they can do the most thorough investigation ever, and they're not going to find anything. They're not going to find anything to treat, right? So what do we do about that? And what does that tell us about the nature of the disease? And then I'll just briefly say that there are studies about other risk factors, mostly physical injury. And this is not as good a systematic review. That they included uncontrolled studies and didn't control for psychological stressors. But they did find a signal for physical injury inducing functional disorder when compared to movement disorders. And that included trauma or surgery. So there are some case reports of patients developing functional symptoms after surgery. Okay, well, let's go a little bit deeper and look at what functional neuroimaging has to tell us. I'll also be presenting a review here. So this is an article that was published in 2016, and I like it because it looked at all the fMRI, PET, and SPECT studies done up until that time. It was very thorough. Obviously, it has qualitative data from it. This is just a little word bubble, just to show you how complicated this can be, all the different areas of the cortices involved and stuff. So very, very difficult to come up with a unifying mechanism. But I've kind of tried to distill it down from my reading of this article here. So there seems to be a top-down regulation from higher order areas to interfere with normal sensory motor function. And what it's some examples of that. So there's a heightened self-monitoring and interoceptive attention. So these patients with functional disorder were found to have increased activity in the dorsolateral prefrontal cortex and the supplementary motor area, which are involved in not only initiating action, but then monitoring action and giving us information from internal stimuli about how we're doing. There was a reduced activation of the right temporoparietal junction. This is an interesting area. It controls what we subjectively experience to be voluntary versus involuntary, and controls our sense of agency. So a hypoactivity there will give you a subjective experience of involuntariness and failure of sense of agency. And here's an interesting experiment they did to healthy controls. They stimulated the right TPJ and it produced an illusion of movement control. So it looks like this right TPJ is really important in functional disorder. There was also altered somatosensory motor processing. So instead of increased activity in the sensory cortices, it was decreased in those thalamus basal ganglia, increased in the paralimbic area, the right TPJ, the bilateral DLPFC, so altered there. And then I thought this was interesting, increased activity in the periaqueductal gray, which is, can cause a freeze to response threat, similar to what's seen in catatonia. And so you can imagine how that can precipitate a functional disorder there. Now, and then in case anyone thought this was still feigning, so they did look at healthy controls and asked them to feign, and then they compared those activity, brain activations to conversion disorder and also the healthy controls. They found that feigners actually had the same activation pattern of healthy controls, so primary and secondary motor cortices, decreased SMA activity. conversion disorder patients had a different activation. So reduced activation in multiple prefrontal areas, but an increased activation of the contralateral primary motor cortex, which means this is what you would expect in someone who's trying to move. But a reduced activation in the right TPJ, as we mentioned, that controls our sense of agency, and the DLPFC, and an increased activity in the left cingulate gyrus, which is part of the limbic system. And then just briefly, there have been studies as well about structural changes in patients with functional disorders. So it's technically also a structural problem. And I didn't really go into detail into this article, but you can see all the, the areas that are implicated. And interestingly, they're kind of starting to look at machine learning algorithms who can look at these volumetric analyses and find differences, and seems to be sensitive in diagnosing functional patients. But I haven't looked into those studies very thoroughly, but just to say that that's out there. So what works for these patients, right? Because I think that's instrumental about what we do when we see them. So there are systematic reviews published about this, but they draw no conclusion just because there's such a paucity of good evidence. Even a Cochrane review said we cannot draw any conclusions, which that's, it's bad, right? And so I'm just going to present some key RCTs here. So this is probably the largest RCT done in this field. CODES, the Cognitive Behavioral Therapy for Adults with Dissociative Seizures, which is non-epileptic seizures. And this was done in the UK. It ran in 27 centers, England, Scotland, and Wales. And it ran between January 2015 and May 2017. Patients were one-to-one randomized to the control group, which is standardized medical therapy versus CBT plus SMC. And standardized medical therapy here is having a neurologist diagnose the disorder, explain it, give them a standardized leaflet of information, send them to psychiatry, who also do their explanation and probably provide some supportive psychotherapy. But the key was that they were not allowed to provide CBT, right? And then the intervention arm, obviously they did CBT, had about 180 patient randomized to both groups. And then the patients were followed for a 12-month period. Primary outcome was monthly seizure frequency, and then several secondary outcomes that I'll show you in a second here. So what was the result? Unfortunately, there was no reduced, monthly seizure frequency. And the seizure severity score also did not change with CBT. So, you might say that's a negative trial, but several important secondary outcomes were met. So seizures were less bothersome to patients. There was a longer period of seizure freedom, right? So even though the frequency is the same, the patients are going longer without having seizures. They improved in functioning, psychosocial functioning. Patients reported that they felt better, and then clinicians reported that patients looked better, right? And so even though their seizures were not reduced by CBT, it seems like it did impact their quality of life. So that's important. What about pills? Has anyone looked at SSRIs and if that works for non-epileptic seizures? So no, there's not a really good RCT out there, but there's a pilot RCT done by La France up in Rhode Island. And it was a very small trial. So it ran between July 2002 and June 2008. 19 patients received sertraline and 19 received placebo. It was a flexible dose sertraline, so they started at 25, increased to 25 as tolerated. And so most patients tolerated at least 100 milligram doses, 10% tolerated up to 200 milligrams. Primary analysis showed no change in seizure frequency, right? They did some post hoc analyses, which showed 45% decline in biweekly seizure ratios in the treatment arm, but a non-significant increase in placebo arm. So that seems sketchy. I think for all intents and purposes, this was a negative trial. And then the authors justified it by saying, this is a pilot study. We're just looking for effect size. We're not trying to prove efficacy. We're just trying to plan a bigger RCT. But La France never did that. But he did do an RCT. Oh, and secondary outcomes, no change in depression, anxiety, and impulsivity. He did do this RCT a few years later, where he showed, does combining CBT and sertraline provide any added benefit, right? And just briefly, psychotherapy and psychotherapy plus sertraline did show a statistically significant improvement in seizure frequency, but not sertraline at all. So it looks like SSRIs don't work. Okay, what about physical therapy? You know, we all know that that's important. I'm not sure how often we refer functional patients to PT. Yeah, Ben is nodding his head. He does it all the time. I hope everyone's like you, Ben. But you know, you've got a lot of experience with these patients. But anyways, so how good is it, right? And so this is a RCT of physical therapy with a 1-year follow-up. And so this was a crossover study, meaning they allocated one group to 3 weeks of intense inpatient rehab and then a 4-week waiting period. Other group had a 4-week waiting period and then did the inpatient rehab. And then they followed up for a year to see what happened. So they used adapted physical therapy, which is a physical therapy with education and a CBT frame of reference. So what does that mean? So the therapists themselves presented an alternative understanding of the patient's symptoms. So they said there was no exact explanation for these symptoms, but that they commonly occur after stressful life events, right? So presenting the stressful life events as a risk factor instead of an actual etiology. They positively reinforced normal functioning. And then the positive feedback was withheld when there was no improvement. So negative reinforcement. So this is, you know, operant conditioning, you know, CBT principles. Minimized attention to sickness or illness behavior. And then they told patients, hey, you know, if there's no improvement, we might cut to 3 weeks. So that was an extra motivation for patients to be engaged in physical therapy. And really the results were pretty good. So this is a functional mobility scale and functional independency measurement scale, and both were statistically significant and clinically significant. They saw a large, you know, increase in those scales. So a lot of patients were helped back to independent living where they weren't living independently before. Many were able to return to work. And then looking at them 1 year later, they kept their gains, you know, so this is just 3 weeks of physical therapy. And then a year later, they're still doing well.
Ryan, can you go back to that slide?
This one?
Yeah. Does that mean they both wind up in the same place, the controls and the patients, they just do it quicker?
Yeah, so it's a crossover study. So both of them receive the physical therapy, but then to do the analysis, you look at, you compare each group to itself, basically.
Okay.
All right.
Oh, I see what you're saying. So it's only, the randomized part is only the first 2 time points, then you switch them over. I got it.
Anyways, so they kept their gains 1 year after follow-up, and patients with durations of symptoms as long as 4 years responded. And the authors are really excited about this because the classic teaching is the longer that functional symptoms go on, the less likely it is for them to respond. It wasn't the case in this trial, so that's good news. So what happens if you combine CBT with physical therapy? This is, again, no good RCT, it's just a pilot RCT, unfortunately. This was actually a letter to the editor. It wasn't even published as an original research paper, but they had 3 different treatment groups: CBT alone, CBT with adapted physical therapy, and standardized medical care. And the primary outcome was a psychogenic movement disorder scale. Secondary outcome were scales of depression, anxiety, and PHQ-15. And in summary, there was significant improvement in all outcomes, both primary and secondary, in both intervention groups compared to the control. But then there was no difference between the 2 active groups, meaning if you got CBT or CBT plus physical therapy, you improved, but there's no difference with adding physical therapy. So that's kind of interesting. The authors blamed that on the fact that most of the patients in their trial had tremor, which is less responsive to physical therapy than gait and dystonia. So, you know, that might be it. Okay, so those were the treatment trials. So kind of some take-home messages, and then I'm gonna, doing good on time, going too fast, I don't know. So some take-home messages. So as we saw first, you know, the explanations that we may routinely use for functional disorder are based on some Freudian ideas that are not necessarily scientific or kind of belong to a different type of time. When we look at the objective data, what we can say is that psychological stressors are a major risk factor for the development of functional disorder, but there may be other risk factors like physical illness. Some studies looked at effects of medications, neurological disease, although that kind of gets into the weeds of functional overlay. But and then if you look at functional neuroimaging imaging studies, there does seem a definite mechanism does not arise, but there does seem to be differential activation of certain, brain areas causing inhibition of normal sensory motor processes by higher order areas and limbic areas. And then the strongest evidence for therapy is for physical therapy. There's mixed evidence for CBT, but it probably helps in some measures, maybe not solving the problem. And then it doesn't seem like SSRIs have helped based on our current understanding. And then kind of before going further, I just want to say caveat, when we see patients with functional disorders, they're not always truly functional, are they? We know that patients malinger and have factitious disorders. Obviously, you have to give them the benefit of the doubt. Functional overlay, which is very challenging. And then we kind of have to be humble and, acknowledge that sometimes we miss diagnoses that are neurological because they're, bizarre. We haven't heard of that syndrome yet, right? They turn out to be a truly neurologic disease. And sometimes, it might be a syndrome that hasn't been discovered yet. So just kind of to keep it in mind when you see these patients in clinic. But here's a review that I really like. Oh, TMS, yes, Dr. Haas, there is a small trial of TMS stimulating that area of the right TPJ. And there was it did show some benefit, but it was a very small number of patients. And so I didn't include it, but yeah, that's been looked at. Anyways, so this is a really good review article, Functional Neurologic Disorders, New Subtypes and Shared Mechanisms. It was just published a couple of weeks ago, actually. Professor John Stone there, the corresponding author, was the author on a lot of trials that I presented, and he seems to be very prolific in this field. It's a really good summary. I really like it. I'll just show this panel 3 that they included, which seems like to be like advice that they're giving neurologists about how to approach these patients. So common reasons for missing a wrong diagnosis, meaning that we diagnose patients with functional disorder when they don't have it. Jumping to conclusions based on a patient's psychological history, right? We see patients who have significant anxiety, depression, or maybe they just seem that they're going to be functional, right? And we diagnose them with that, and we're not always right. Sometimes they have MS, right? So then diagnosis based on a bizarre presentation. So that's what I was saying, that we don't know everything, right? I mean, there's a lot of syndromes that we've never seen that might be neurological, and so it's just kind of a word of caution there. Common reasons for missing a diagnosis, meaning not giving someone a diagnosis of functional disorder when it actually exists. Absence of psychological risk factors, right? So you see a patient, seems functional, but it's usually he, right? But he doesn't seem like he would have those risk factors, right? It doesn't give a functional vibe, quote unquote. And so that's a mistake, because as we've seen, you don't have to have psychological risk factors, right? It seems like the etiology is more complex than that. The clinician should explain the diagnosis to the patient on the basis of positive clinical findings. So this is not what we do, right? We treat it as a diagnosis of exclusion. We tell patients, oh, we've looked at everything. We don't find anything wrong structurally with the brain. So I'm going to explain functional disorder to you. And I think that's problematic because it kind of gives the impression that we haven't found anything, and so we're blaming it on a psychiatric disease. Obviously we want to be good clinicians and rule out, dangerous neurological disorder as well. But I think that's where the authors are coming from, that it should be a diagnosis of inclusion rather than exclusion. Granted, I think these are psychiatrists, so they don't have the same problems that we do. But the clinician should not make a diagnosis of functional disorder based only on normal radiological and lab diagnostics. So that's kind of going to the same point. They say do not frame the patient's diagnosis as a medical mystery. So, that would encourage doctor shopping and ordering too much tests and so forth. Do not highlight risk factors like stress or psychological risk factors when discussing possible causes. I think that's very challenging, and I don't know how that would apply to actual practice, because even though we've seen that these aren't necessarily the cause of functional disorder, it's hard to ignore a major risk factor that can be potentially intervened on. So I don't know if I would do that. And then do not encourage unrealistic expectations. Improvement is a gradual, active process. Many patients do not improve. Some outcome studies have shown that up to 7 years, a significant majority of patients still have their symptoms, right? So improvement is not the rule, basically. So, okay, based on all that, I'm gonna try to give a functional talk, like a modified functional talk. I don't know, Ben, do you want to be my patient? It's helpful to feel like I'm speaking to someone, and you can react if you want to.
I'll react negatively to everything.
Yeah. Okay, so this is more based on motor functional disorder. Obviously, you'll have to adapt it to sensory or something else. I think what you have is called functional neurological disorder. And well, I'm about to explain it to you. And this is based on some signs I've observed on your exam. Okay, so for example, even though you're unable to lift your leg when I'm pressing against it, you're able to lift it when you stand up. So this here, I'm trying to embody the diagnosis of inclusion that the psychiatrists recommend. And then, so research studies have actually looked at brains of individuals with this disorder. We found a problem with areas of the brain that plan and regulate movement, okay? And we also found a problem in areas that control our perception of what movement is voluntary or involuntary, okay? And so that means that even though you perceive that you're unable to move your leg voluntarily, yet you might perceive that, but you do have the capacity for it.
Now, doctor, that's a lot of words. What are you trying to tell me?
You're supposed to say you're saying it's all in my head. Okay.
Are you saying it's all in my head? Sorry, I'll follow the script.
Guys, we didn't rehearse this before. So here, it's important to put this caveat. So we know you're not faking it, okay? Because we looked at the brains of individuals who were faking it, and their brain activity looks very different. So I don't know if that makes you feel better or not, Ben. Okay.
My leg doesn't work.
Okay. Wow, he's making it hard for me. I should have just picked Elijah, like less resistance. I don't know.
Chose poorly.
No, actually, he seemed to be stronger. Okay. So what are we going to do about it then? In terms of treatment, we know that physical therapy can be very helpful in retraining the brain to initiate and regulate movement correctly. So I'd like to refer you to physical therapy. And then there's also a specific type of psychotherapy that's called cognitive behavioral therapy that focuses on correcting the perception that we talked about and that modifying behaviors that may be maladaptive. So I'd love to refer you to them as well. Okay. Oh, wow. Okay. It's a first functional patient who wants to go to psychiatry. Okay.
So are you saying it's in my head or not in my head?
Well, I don't know. I don't know what to tell you. So obviously this is an ideal situation. I don't think it would actually go down like that, but just trying to incorporate some of the some of the principles that review suggested. So that's the end of my talk. Thank you everyone for your attention. Thanks to the faculty, for your training and everything over the years. And there's my awesome chief class. We look pretty good at that picture. Well, I was gonna ask Kuya if anyone important is missing, and Kuya's supposed to say no, and I'm gonna say yes. Elijah's missing. Come on.
No.
we have to find a way to Photoshop Elijah in there. Thank you to my family there on the left. We went roller skating, and thanks to my partner Mackenzie. She's great. She helped me prepare for this presentation. And then I'd like to just show some pictures of my pets there. So Quaid on the left, he was the nicest little guy. He passed away in January. So, but that's our new Papillon. That's Chief. And then Louise there. She's wearing the beret. She's always angry. It's not because she's wearing anything. So anyway, so thank you all for your attention, and I'll take questions and comments.
Thank you, Ryan. That was wonderful and really tough choice. So do farmers get functional disorders? I mean,
Dr. Brian, it's so interesting you mentioned that, because I remember seeing a patient with Dr. Morgenlander who was a farmer, and he was having these tremors, and we're like, I don't know, it doesn't really fit, it's maybe functional, but he doesn't seem functional. And so that's kind of what I thought of when I was reading that review paper, and kind of brings to home that you have to think of functional patients without like stressful risk factors. I think the pathophysiology is complex, and probably stressful life events are just a risk factor, a major one obviously, but you don't need it to get it. So.
Nada, you have a question?
Yes, thank you for a great talk, Ryan. I have two quick questions. One, do you know if functional studies, like MRI, would differentiate malingering from conversion?
Yeah.
And it does. And then two, do you know if there is any study regarding cultural prevalence? Like, is the prevalence of functional disorder differs across countries or cultures?
Yeah, so for the first question, so they did study brain activity in functional patients compared to feigners. So that would theoretically be the same as malingering or factitious, although you can imagine they have different motivations in a research study than in real life. So there's some limitations to that. But there were differing brain activation patterns. I can go back to that slide if we have some time. There we go. So feigners, which I think would mimic malingering, they had the classic activation patterns of primary and secondary motor cortices and decreased SMA activity. So they're not self-monitoring themselves as much. Whereas functional patients had decreased activity of prefrontal cortices, but increased contralateral primary motor cortex and decreased right TPJ. So it seems like it's possible to differentiate them. I don't think it's made it into clinical practice, but there are some studies like looking at that. I think there are differences based on the cultural background, and I did come across some studies, especially in the Far East, studying how functional disorder is different there. But to be honest, I didn't go into them, but I think there is a difference.
Len White, you had a question and a point.
Sure. Thank you, Rich. Great talk, Ryan. I really enjoyed the topic and your perspective, particularly the historical survey that you led with. I was interested to see the right TPJ show up in your analysis of the literature. And in cognitive neuroscience, it's interesting that this area shows up in numerous studies that suggests that it has an important role in what we might broadly describe as pro-social behavior. And I'm just wondering what you make of that. You're perhaps identifying a more mechanistic component that might be more broadly understood as pro-social. I'm just wondering what your thoughts are. Thank you.
Yeah, I don't know. I think I can see the existence of functional disorder within like a social framework, right? And so if there's certain social factors, obviously that trigger it, again, we know that those are risk factors, then the right TPJ can be affected. But yeah, again, I don't know, like in terms of the mechanistic way, how that affects movement at the end of the day, I think that the self-agency and the sensation of involuntariness, explains that well. But yeah, I can see how, because the most popular view of functional disorder now is looking at it in a biopsychosocial model, and so I'm sure it's involved. But yeah, in terms of like the end product, how it causes weakness, right? I think it's because of the sense of agency, maybe. So.
Saurabh?
Thanks, Rich. Ryan, that really was a great job, and it's an important topic. I just want to kind of a couple of comments and a couple of things that I think either you mentioned or other people mentioned that I think are really critical. One is, you talked about kind of weakness and sensory problems, and you mentioned tremor. And I think, it's more realize that really every subspecialty in neurology probably has their functional neurologic disorder. And it's, I think the approach to them, including both presenting the diagnosis, but also the treatment and management probably varies a lot by that. And, there may really, I wonder if some ways there might really be different conditions, at least in the epilepsy world. People are making some efforts to really maybe even classify different subtypes of non-epileptic seizures and non-epileptic events. And I wonder if that may be why some of the data gets so messy, is when people try to do these big reviews, they may really be lumping together different conditions and different diseases. The other comment, just I think Dr. Massey mentioned this, or I can't remember who, but I think it's really critical that when you make this diagnosis, that once you present the diagnosis and make the referrals, that your engagement shouldn't end there. Because these patients, I mean, even though we present it as sometimes as a positive diagnosis, these people do not do well. They will end up in a different clinic, undergoing different treatment and start the whole process again. So staying engaged with these patients is really critical. You got to give these people a follow-up to return to your clinic to see what they're doing. And even if they're not doing well, to either reassess your diagnosis to make sure that you didn't get it wrong, like you mentioned, and then also to just make sure that they don't end up, going down the road again. There was in the epilepsy world, the one study about 20 years ago looked at patients who were given this diagnosis, and 5 years later, more than 2/3 were back on seizure medications for epilepsy.
Yeah, thank you for those comments. I think that for sure, I think it's a heterogeneous disorder, and that's probably why we get mixed data. And this review here is trying to subcategorize the subtypes, and I think that's a great step forward. So, thank you.
I have a comment. Is there time?
Sure.
Yeah.
Ryan, thank you so much. Saurabh is so right with what his comments, but I mean, first thing that is obvious to all is to gain the confidence, and even if you can convince Ben next to you on where to go from here, it starts with the fact that he trusts you, and he trusts you because you did the complete neurologic examination and history and showed care, and we have to not forget that. Even more important than the MRI and all the other things is your relationship to that patient. And I agree with Saurabh that you don't refer them on and then just forget about them. They need to know you care about them, and I know you know that. I do have a second comment, is that I think abuse, whether it be childhood or adulthood abuse, we just ignored for, at least in my 50 years, we didn't talk about it for many, many years. Fortunately, we are aware of it more now, and I think it's more prominent than we once thought. All right.
Thank you, Dr. Massey. And actually, I didn't mention this in the meta-analysis, but it seemed like childhood abuse, specifically emotional abuse, more than physical or traumatic abuse, seemed to be more statistically significant. So they calculated something called a PAF score, which signifies how much you can attribute a certain risk factor to the development of the disorder. And PAF scores in this meta-analysis I presented first were highest for emotional abuse in childhood. And so I think you bring up a great point.
Thank you. Key Van Lanningham, you had your hand up, but I think you've disappeared.
No, I just wanted to reiterate the Masseys, I think, are spot on with abuse, because that's one of the key features that you really have to delve in. And I agree, the referral pattern, probably the most interesting case I saw was a woman in her 60s who had grew up in North Carolina, started having what were labeled seizures, sent up to New York, had a bilateral frontoparietal craniotomy, so-called jack-o'-lantern skull x-ray. And here she was in her 60s, her husband had died, she'd moved back to North Carolina and started having the same spells all over again. So this is a disorder that's often lifelong for many of its patients.
All right. Mark Hallett is just retired from the NIH, but there is now an international functional neurologic disorders society that he's in charge of, which it's now a new passion for him. And that's where this review comes from. So anyway, Ryan, thank you so much. Everyone have a great day and a great week, and stay safe.
Thank you.